Should go ahead and begin. So hello, and thank you for joining our final breakout presentation. Before we begin, I would like to note that this session is being recorded. It will be made available after the symposium for 30 days on the symposium website. After that, all recordings will be transferred to the NNLM YouTube channel for later viewing. Up first, we have Dr. Terri Powell, Associate Professor and Vice Chair for Inclusion, Diversity, Anti-Racism, and Equity with the Department of Population, Family, and Reproductive Health at the Johns Hopkins Bloomberg School of Public Health. Dr. Powell leads the B Lab, a Baltimore-based research team helping to create a world where all youth are safe, healthy, hopeful, and connected. Partnerships with churches, schools, libraries, families, and community-based organizations are a cornerstone of her research. Most recently, she led the development of the Better Together Intervention, an age-appropriate, culturally relevant 8-session library-based intervention designed to prevent early substance use among Black youth affected by parental drug use. Her goal is to ensure that youth, especially those affected by trauma, have multiple pathways to achieve optimal health. Everyone, please welcome Dr. Powell.
Thank you so much, Tony, for the introduction. And hello, everyone who's joining. I should start off by saying I'm an avid lover of libraries, even non-research based. My family and I, we go to the libraries. I believe that libraries are a place for adventures. So I'm so excited to be able to talk a little bit about the ways in which I've worked with libraries in my professional life. So today, the title of the talk will be Libraries, Public Health Partners for Health Promotion. And many of you may already know some of these things. So I always like to start off with acknowledgement. So even though you see me, I am held up by lots of other people, folks who have funded our research. We've been partnering with young adults, the Enoch Pratt Library, which is the library here in Baltimore, Maryland, and many partnerships with the Center for Adolescent Health, which is located at Hopkins as well. A number of consultants, some of which who are youth, all of which have been Baltimore-based or urban-based. The participants, folks who continually talk to us, and of course, the rest of my research team. So I always like to say thank you to them so everyone understands that you see me, but I'm just one of a huge team of people doing this work. So first of all, I like to start with just an overview of like, what is public health? So the easiest definition is that public health is the science of protecting and improving the health of people and their communities. And so the reason I think it's important to start here is that often when people think about health, we instantly go to healthcare or individual health. But instead, public health, the idea is like, how do we create systems and how do we understand injuries and disease and health so that most folks or everybody can proceed and have a healthy lifestyle. And so what does it look like? Promoting healthy lifestyle. So what do we know that works with most folks about how to achieve optimal health? Researching disease and injury prevention. We understand that, life is not just having a good, healthy life. It's not just the absence of disease, but also the prevention of some things, but then also the well-being. So lots of public health research looks at not just, physical health, but mental health, sexual health, social well-being, cohesion in communities. And then ultimately, like, our strategies are to detect, prevent, and respond to infectious diseases. And one of the most recent, of course, being COVID. So I'm sure you've seen lots of public health professionals talking about that as well. And so, as I said earlier, like, it's concerned with the health of the entire population, so not just an individual. So while everyone's individual story is unique and important, public health, it really wants to take a combination of stories and say, how do we now make sure that everyone can achieve optimal health? And so when we think about what a population is, it can be as small as a local neighborhood or as big as an entire country or region when we're looking at health trends and patterns. And so this, what do we know about libraries? Like there are nearly 17,000 public libraries branches in the US. And if we included school libraries, it almost 120,000 libraries. And so if we think about it, there is research to show that public libraries serve over 95% of the population. And that is including from like, cradle to grave, all in between, the babies, the old elderly. And one of the things that I've loved about working in libraries is that they are located across neighborhoods. So whereas sometimes research centers or hospitals are not necessarily not as easily accessible to some communities, libraries are. Like they are the places that they're usually, many of them in a city or even in rural communities, and they're able to service like folks across the income strata, urbanicity, and age strata. And of course, as you all know, libraries are considered safe and welcoming places with low barriers to entry. And that last part is really important because if you think about it, what place do we know now where there are no costs, or you don't have to fill out some kind of like entry form or something like that? So thinking about one, having these accessible places that folks feel like they can go in, not necessarily be bothered, not have to pay a ton, get some resources. Libraries are real assets to communities. Again, that goes to, why I love libraries so much. And so I really want to get into, and these are just some, and I'd love for folks in the discussion to tell me about some of the programs that your libraries have had. So I pulled out some of the incidents that we've seen in the literature and that I've heard about at other library conferences about the ways in which libraries are supporting community health. And so for me, this is how libraries are partnering with public health departments and universities to address public health. So here in Baltimore, one of the big problems that we've seen is like substance use and overdose, so much so that there's been overdose in some of our libraries. And so in order to address this, many of our librarians here are now stocking naloxone and training staff to administer naloxone to patrons who have overdosed in the library. And most recently, they've extended this training to community members. So every other Friday, anyone from the city of Baltimore can go to 2 libraries and receive training on naloxone, because they recognize that perhaps like it's not just the librarians who need this training, but also folks in the community who may have family members who are struggling with addiction, or family members, friends who may be struggling with addiction. Our libraries also offer a social worker and legal aid services in the libraries. And in some research, I know that isn't unique, but I also know that it is not widespread for all libraries across the country. And I'm really excited to have been working with our Pratt Library here in Baltimore, because their social worker program not only is connected with our School of Social Work, but those students are connected with the library as well as some of our local schools and able to provide the support that some of our students need. And similarly with the legal aid services, we have lots of returning citizens in our communities, and helping those citizens like get the identification that they need, apply for jobs, or even challenge some of the charges that have been some of the lingering issues related to their detainment have really been an asset to the people in our community. And one of the things I want to say about each of these examples is that they are unique to the community. And that is, again, what I love about libraries. Like, there are clearly a set of services that all libraries across the country are offering. But the fact that there are some libraries who have also partnered with, again, health departments, universities, hospitals, to be able to identify and then address some of the issues that their communities are facing has been amazing to see. And so in Greensboro, North Carolina, the libraries there, they noticed that physical health was an issue. And so they partnered with the library to address food justice and to develop fitness programs. So I think about, it's not just the YMCA, or it's not just your local gym where you can go. They were offering Zumba classes, and move classes for the little kids, again, to start to develop this sense of like health and healthiness at a young age, but also making it family friendly, because again, the library serves 95% of our population from like birth to death, right? So, and in Charleston, South Carolina, there's a program called WISE, which stands for Women in the Southeast. And they recognize that women were having challenges getting to their hospitals, especially with the travel. And they wanted to offer high quality healthcare to women. And so in an earlier study, before they started partnering with libraries, they asked residents, like, where would you go? Where would you want to go? What's near you that you could be able to go to have a telehealth visit? Or if we had like practitioners come to offer some like low basic kind of like answer questions, where would you go? And libraries emerged as a place. And so they started partnering with the libraries, the health system there, to be able to offer some of these services to women, especially those in the most rural areas, and they have like a little mobile clinic now that goes out. I mean, it's been really incredible to see develop over time. And then in San Diego, again, thinking about what are the issues that are important to cities. As you know, San Diego is close to the border. There are a number of folks who are coming across the border, living in San Diego, who are interested in taking the citizenship test and going through that process. And so they now offer citizenship classes. This isn't something that is a huge issue here, but perhaps in other border cities, this might be a model for other border cities to be able to think about, how do we service the people in our community, and what are their needs, and what can we do to address them? And so most recently, we've seen lots of examples of libraries supporting COVID. Again, I'm sure this is not an exhaustive list, just a list of ones that I know of. And the ways that libraries were also supporting COVID efforts. This was one of the biggest public health challenges of our recent times. And so being able to have all hands on deck has, again, like really helped us drive down the deaths and hospitalizations of folks. And so in Bucyrus, Ohio, and even here in Baltimore, our libraries partnered with the health department to distribute at-home COVID tests. And then later in the most recently here in Baltimore, all our libraries were offering free at-home tests. So before our government started to send them out, they're like, hey, we have tests, we want people to get them. Come to the library on a Saturday morning and pick up. Each family can and you didn't even have to have a library card, but each family can pick up an at-home test. And this is really important, especially if you think about earlier this year during the surge in January, when kids were going back to school, everybody was really nervous. So being able to have a free at-home test or set of at-home tests for the family was really important, because they're not cheap. If any of you like me have like bought lots of those tests, like you can really rack up a bill. So this really came in handy for families, especially who needed at-home tests. In Pottsboro, Texas, they were offering telehealth. So if you think about during COVID, folks weren't really going out, like hospitals were overrun. And so they offered telehealth services to inpatient navigation to increase the access, again, for rural and elderly residents. And if you think about folks who were most affected by COVID in the earlier days, it was our elderly population. So making sure that, not only were they being safe and protected from COVID, but, the older we get, the more health issues we have. And so if people aren't able to get the medical care that they need to prevent some of those issues, or to keep their chronic conditions at bay, we could have seen a lot more death. So they partner with folks in Texas. Libraries partner with health departments and medical centers to be able to provide those services. In Maryland, but not in Baltimore, in Prince George's County, there, when the vaccine first came out, they created a whole vaccine hunter hotline. I was so impressed to learn about this. They literally, these are people who you could call them and they'll tell you, like, this place has the vaccine. Because if you remember, lots of folks are very eager to get the vaccine in the initial days, and they were running out, or people were confused about what the eligibility or who was in which group. And so they created a vaccine hunter hotline to be able to help people get the vaccine as quickly as possible. In Ohio, in addition, we were in COVID and everybody was digital, but not everybody had a digital space. And so we, both of these cities offered longer and more hotspot rentals so that we could increase broadband accessibility, especially for, again, the kids who are going to school and who relied heavily on internet services to be able to learn. So lots of wonderful things already happening with these partnerships between libraries and public health entities. And so as I just want to kind of wrap up with, and I still think there's more to do, and I'm so excited to be a part of some of this work. And so one of the things that we've learned is that public health libraries and public health partnerships can continue to offer trainings for librarians and library staff in general. In a way that we've seen. My team conducted a study last year of 269 library staff across the country from 37 states. And we learned that almost 85% of folks had received some kind of training on a health topic. And they said that we were interested specifically in like youth health topics. And they said that, yeah, we'd be comfortable talking about sexual and reproductive health and substance use and infectious disease. I think some of these larger issues that our Surgeon General, as well as our public health agencies have declared as public health issues, things like racism, as well as violence, those have become public health issues, but still a little less, folks are a little less comfortable talking about those. And so I don't think it's like unique to library staff. I think that many people are uncomfortable, but there are a number of trainings being developed. And I think that we can start to extend those trainings from public health professionals to library staff as well. I think given the fact that many librarians are excited about being trained or have received some training, we can also start to think about what would it look like to host interventions for young people and families in libraries. So often we partner with schools because that's where kids are, or we go to work sites, or we go to other places where people are already situated. Well, we know that people are also going and accessing the library. And so similar to the other programs that are already being offered, what would it look like to offer programming around trauma-informed strategies, or sexual and reproductive health or substance use? Like, what would that look like, and how might we be able to support libraries and library staff to be able to invite people to those and then feel comfortable and capable in addressing some of the issues, or even connecting people to services if they were able to be a part of those programs? And then the last point I think that I hopefully started to show in my previous slides were about really extending health and telehealth services. We've seen it happen in rural areas for women and elderly. I think that we can probably push the envelope, right? Like, how do we now partner with like other healthcare providers to think about mental health and well child visits? I think that the hard part there would be us thinking about what would space need to look like to be able to provide some of these confidential services. But I don't think that is an insurmountable barrier for us to climb, especially given all of the work that librarians and public health folks have already done. I think now we get in-home testing, maybe we extend it. Like, what would it, like some of our libraries here have been vaccination sites, right? Like, they set up clinics outside in the parking lot, some of the drive-through testing spaces. How do we extend that? And are there ways that libraries can support those efforts as well? And then finally, just connecting to some of these other broader social determinants of health that affect that may be equally important. So not just the individual health, but how do we help families find housing and support? I've seen lots of places that already have job programs. So like thinking about housing and food, connecting to those types of services, or even like inviting those services in to say, hey, on this day, you can come and we have our food pantry or something like that. So I think that there's so many great things happening already. And I just wanted to make sure I left folks with some other ideas in case you've done all of the things on my previous slides. I think there's still some space where libraries and public health partnerships can really support communities. So this is my kind of last slide. Like, the big takeaway messages I hope that I've been able to communicate is that partnering with public libraries, both from as a public health professional, I think it'll only extend our efforts, right? Like, I think we need to figure out how to get as many people on board. And it doesn't require like, oh my gosh, I have a master's of public health or a PhD to be able to help communities. Libraries are already doing that. And so I think the more support that we can give, the better they'll be able to do that. Clearly, libraries are public health assets. So not just assets in places where people can go get books or rent computers, but really like these are places that are providing services to help you. They have been. And we're moving into a new normal, I think, and I've been impressed with the library's ability to, even our library now, you can get your virtual library card and rent materials, like any virtual materials. And when you want to come into the branch, you can come and get a hard card. So I'm really impressed with library's ability to be adaptable and flexible to the needs of community members and the changing times. And I'm most excited, and I hope that you would agree, that librarians and library staff are ready and willing to support youth and families. This is the part of what they've been doing. And so for us to be able to just provide additional support to elevate these efforts would be the perfect match in my world. And so that is that. I'd love for anybody, we can have conversations after this, but here are also ways that I can be found, or you can learn more about the work that my team is doing.
Thank you, Dr. Powell, for your presentation. It looks like we had time for about one question before we move on to Stacy's presentation next. So one question that came up is, what are best practices for evaluating health programs implemented in libraries?
Yeah, and I think that's a great question. Thank you so much. I don't know if it's in the chat or not. I can't see. I got too many screens going. The way to evaluate it is first I'll say a couple of things. One, I think you need to be clear about what you want to evaluate. Like, what is the thing you want to happen based on your program? So once you're very clear about, okay, I'm doing this program to increase engagement or to reduce X or to increase Y, being clear about what you want to happen. And then the researcher in me would always say, like, do a pre and post test. So anybody who enrolls in a program, like the first thing we do it now, like during COVID, we really got skilled at offering online surveys. And we have a system at our university we use, but this can be as easy as a Google form, right? Like everybody who enrolls, you say, like, I want to ask these 4 questions, like, what do you hope to get? And then, maybe you want some knowledge questions, maybe you want behavior questions. And then you just ask that same survey at the end and compare the responses. You don't even need to know people's name. You can kind of look and say, like, oh man, like we had a scale from 1 to 5. They were 1 before they started, but they were like 3 when they finished. Like this quote unquote works. So those will be the 2 things. First, like really identify what you want to measure and evaluate. And secondly, try to create a form that you can ask multiple times, both before something is offered and then after it is offered. And I'd be happy to, whomever asked it, I'm happy to like brainstorm what those questions might look like, because there may be ways to create questions so that they can span multiple programs. And so you're not like creating like a million surveys for patrons to respond to.
So I don't see any other questions now, but if people have questions that they would like to ask, please feel free to ask them in the chat box. And after Stacy's presentation, if there's time for you, Terri, if you're available to answer questions, that would be fantastic. So if you'd like to stop sharing, I would like to introduce Stacy Stevens. She is faculty and clinical instructor at the University of Maryland School of Social Work and director of Be More for Healthy Babies at Promise Heights. With meaningful partnerships with residents and community partners, she has led the Be More for Healthy Babies team and accomplished a 75% reduction in infant mortality rate over the past 10 years. This has resulted in the elimination of the disparity between Black and white infants in this community. Ms. Stevens incorporates self-care practices into her daily routine, and she encourages her staff and community members to do the same. Stacy Stacy was the recipient of the Social Worker of the Year 2022 by the National Association of Social Workers, the Maryland chapter, and the University of Maryland School of Social Work, Jedi 22 recipient of the Shirley Chisholm Community Award. And JEDI stands for Justice, Equity, Inclusion, and Diversity. And I did ask her if they awarded her a lightsaber, and she said no. But Stacy, please feel free to go ahead and share your screen, and we look forward to your presentation.
Absolutely. Thank you, Tony, so much. It's a pleasure to be with everyone today for this amazing opportunity to present our work. And so I want to start off and join Dr. Powell, as she was saying that she was a bibliophile, that I too entered this space as a social worker and a bibliophile and a great supporter of local libraries across many jurisdictions. I've got library cards for pretty much every county in Maryland, and I have no shame about it. So again, it's a pleasure for me to be a part of this conference today, and I would like to start by recognizing that we are at the end of Women's History Month and Social Work Month, and that many of us are preparing for Black Maternal Health Week, which will be observed during the second week of April. So in honor of this, I would like to start today's presentation by acknowledging the past contributions of those who have fiercely advocated for women's health and well-being. Every woman, every birthing person, historic granny midwife, midwives, currently doulas, birth attendants, public health supports, physicians, Dorothy Heights, Shirley Chisholm, Mary Turst Terrell, mothers who we lost along the journey, sisters, aunties, grandmothers, and fathers who have stood in the gap with their medical green books and raised their voices, demanding that birthing people are heard, seen, and respected and understood during their birthing process and journey. And so we enter into this shared space this afternoon, having been in this international pandemic, I guess, for like 2 years. And we've all been through quite a bit. As public health professionals, as medical and allied health professionals, and librarians. I am hoping that we have been reading and taking note of many of the changes that have been occurring through health and education. And on the screen right now, what we are seeing is an article that was printed in The Nation in 2017. And I'm hoping that we are entering this space with the shared wisdom and truth that when we're talking about what's killing America's Black infants, that it's not race, it's not poverty or education, but that it is racism. Racism is why Black infants are 2 times more likely to die before their first birthday than white babies, and why Black women are 3 to 4 times more likely to have maternal death than white counterparts. And during our time in the pandemic, it was refreshing to see how many of our professional organizations, the American Public Health Association, the American Council on Obstetrics and Gynecology, APHA, and the CDC released statements stating that racism is a public health issue, a public health emergency, and it is a determinant of health. And one of which said the People's Institute for Survival and Beyond refers to racism as amplifying all of the other social determinants of health. The things that we know as where we are born, where we live, where we work, where we worship, where we play, where we learn, and where we age. We're entering this space today knowing that health is a human right, it is a social justice issue. And it is our responsibility to eliminate it as professionals within our disciplines, across fields, and our departments. So during today's presentation, I will give an overview of Be More for Healthy Babies citywide initiatives and focus mostly on the progress of Be More for Healthy Babies in the communities of West Baltimore, Upton and Druid Heights, and share how this collective learning and collective impact work has led to that significant decline in the infant mortality rate in Baltimore City, Maryland. And this has largely been to ongoing efforts of building relationships with expectant people and parents and caregivers, community-based organizations and libraries are included in that, and showing up in a trustworthy manner. And at the end, I will give suggestions of how the libraries and librarians can support community members as they become researchers of their communities. So for the past 11 years, Be More for Healthy Babies at Promise Heights has worked to ensure that every baby born in the communities of Upton and Druid Heights is born healthy and able to live in a thriving family. We are a part of the Be More for Healthy Babies citywide initiative, which uses a collective impact model to achieve the goal of every baby born in Baltimore, no matter who she is, where he lives, how much money her family makes, or the color of his skin, should have the opportunity to thrive and grow into a healthy child. The citywide initiative is funded by Care First, NEKC Foundation, and overseen by the Baltimore City Health Department, the Family League of Baltimore, and Healthcare Maryland Access. At the inception of Be More for Healthy Babies citywide initiative in 2009, 12 neighborhoods were identified as having higher infant mortality rates. And additional funding was given to 3 of those communities so that we could do our own community-based initiatives in those communities. At that point in time, Baltimore City had the 4th worst infant mortality rate in the United States for cities the same size. There were 128 babies that died. 27 of them were because they were placed in unsafe sleep positions, and Black babies died 5 times higher rate than white babies. The communities of Upton and Druid Heights received additional funding through Be More for Healthy Babies Promise Heights. Our programmatic efforts started in 2011, and at that time, the infant mortality rate was 3 times higher than that of white babies. It was 15 deaths per 1,000 live births. And so our place-based initiative is out of the School of Social Work and the School of Medicine. We are charged with reducing the infant mortality rate. And today there are about 10,000 residents who live in the community of Upton and Druid Heights. 92% of them are African-American. The median income is about $22,000 per year. And life expectancy for residents is 56.7 years of age, the lowest in Baltimore City. And so here's a picture that kind of reflects the communities. The residents of the 2 communities are like many others across the country, where persistent disparities in healthcare and healthcare access and outcomes, including poor birth outcomes and maternal health outcomes, is largely due to the built and lived environment and poor social conditions. The picture to the left shows the 2 communities sit and lie in the Black butterfly, coined by Dr. Lawrence Brown, areas that are impacted by red line, which we all know is racial residential segregation, that has resulted in generations of disinvestment. And evidence of this can be seen in the maps that you can see there, highlighting the social determinants of health, including community violence, where there are high shooting calls, high vacancies, incarceration, the lack of green space, and food apartheid. Prior to the pandemic, the factors of community safety, social isolation, and well-being were not new for this community, but pandemic-related stressors, along with grief and loss, contributed to additional strain on the well-being and safety of residents. The picture to the right shows a press conference that was held in the community last summer, where Mayor Brandon Scott announced the accomplishment of our efforts, that 10-year effort in collectively working with residents to reduce that infant mortality rate. And I want to say that that reduction of 3.8 per 1,000 live births is a rate that's below Baltimore City's overall white infant mortality rate. It's well below Maryland's overall rate and the United States rate as well. In fact, that rate is comparable to some counties in Baltimore that are wealthier and other counties that are wealthier across the country. We celebrate that accomplishment with residents who were very much involved in accomplishing that goal. This picture shows many of us are familiar with These are the key determinants of health outcomes, including racial health disparities seen in the 2 communities in which we do our work. The impact that this has on residents' abilities to access healthcare practices and healthcare services is pretty huge. What is not shown in this graphic is the cumulative impact of the emotional, psychological, and spiritual stress experienced by families and community members when they do not receive adequate services, when they are disrespected, ignored, disregarded, overlooked, when they are interacting with racialized systems and structures. And what is not seen in this graphic is the historical and intergenerational relational trauma caused by many of the systems and the sheer of that when folks are engaging with these systems, and the sheer fatigue and the weight as they are encountering racism and other isms. And this can be exhausting to the families that we work with. Interestingly, during the pandemic, Baltimore City was identified as the 4th most stressed city in the US. This confirmed what we understood that residents were experiencing in the community, but it also confirmed what we saw in the data, which you see to the right. Pictured here, we see that the key drivers of poor maternal and infant health outcomes is gestational hypertension. Rising rates of hypertension of women during the pregnancy periods is very much associated with the living conditions and the stresses that residents face while interfacing and interacting with racist systems. All of this can be linked to redlining. And so as we look at all the racial disparities in mortality and health outcomes, they are due to discriminatory redlining practices in Baltimore City, which started in the early 1900s and have set up communities to generationally have poor health outcomes, higher poverty, and lower rates of home ownership. And so when we do our work in Be More for Healthy Babies in the communities of Upton and Druid Heights, we take a cradle to career approach. And Be More for Healthy Babies is the cradle portion of the pipeline of services. Our target population is expectant and parenting families or caregivers who have children ages 0 to 5 and their influencers. One of the key components of our programming as we build relationships with families is that we meet families where they are in their neighborhoods and actively engage with them, collaborate with them, and support them along with other community partners such as faith leaders, business owners, schools, healthcare practices, home visitors, to improve maternal and infant health outcomes. Our team is comprised of perinatal community health workers, whom we call resource parents, certified lactation counselors, social workers, early childhood mental health consultants, early childhood assistants, and a host of fierce mothers, fathers, peer leaders, students from various graduate programs, School of Nursing, School of Medicine, and School of Social Work. We receive referrals from community partners and residents, but our strongest referral source has been by word of mouth from families who have previously received our services. This work is led by community health workers, and we are skilled in trauma-informed approaches, and we are skilled in understanding anti-oppression and power dynamics within ourselves as we are of service to community members. And we also are looking at structural inequities as they exist in services and systems. We use a trauma-based approach when conducting community organizing, outreach and engagement, and while hosting perinatal community-based groups. And those include prenatal support groups, postpartum support groups, parent support groups, social emotional learning groups, and breastfeeding groups. This is a picture of our reproductive health programs that we offer, postpartum care, parenting groups. Many of our perinatal groups were previously held in communities and churches and in libraries, Enoch Pratt Library. on North Avenue, community centers, barbershops, and recreation centers. We are now hosting many of our groups virtually. We generally host about 25 activities per quarter. Participants have shared that the perinatal groups have been informative and that they have allowed residents to connect and deepen existing social connections. And we try to create a welcoming, inclusive environment, one that will support pretty much acting as a buffer to many of the stressors that residents are facing. We also provide case management services and assess protective and risk factors that pregnant and parenting people may be experiencing, and we refer them to local resources and give them diapers, wipes, essential household supplies, and breastfeeding supports. Every day in the work that we do, we are working in our engagement to be trustworthy or be seen by our residents as being trustworthy, because we recognize the great harm that the medical community has caused for many of our participants and residents. And so this process of being trustworthy is a very fluid process. Here you see pictured a model that was created by the Association of American Medical Centers. It's a part of their toolkit for medical providers. It includes 10 principles to increase trustworthiness when engaging the community. The 2 principles shown here are ones that we integrate into our work while building relationships. We recognize that families are wise and that they are expert of their families and their communities. When we enter communities, we enter with deep respect, honoring their tradition beliefs, and create spaces for them to share their wisdom and lived experience. This is highlighting the approach of how we are centering women's voices, valuing their lived experiences, and viewing them as the experts of their family during the perinatal period. This model offers a refreshing strength-based approach to what the social determinants of health and well-being and optimal health could look like as we work to improve maternal and infant health outcomes. And racially and congruent care is important in delivering perinatal community-based services. It's important that we are treating residents with respect and dignity, and that when we are listening to them, we are really making an effort to implement what we have heard into existing programming. And so now on to some of our successes. This slide shows the infant mortality, as we all know, is a key indicator of community health, and it has shown the steady decline and the decrease in the disparity between Black and infant white deaths in Baltimore City. We have also reduced the teen birth rate in the city by 49% and sleep-related deaths by 71%. And this slide shows, again, the phenomenal work that we have done over the past 11 years by reducing that infant mortality rate, looking at the rolling averages from 2014 to 2018, and reducing it to that 3.8. And then being able to sustain it at 4.1. Again, that is phenomenal, and we celebrate that. This is our theory of change that we use in Be More for Healthy Babies. We take a life course perspective. We try to address making these changes, not during just the pregnancy period, but again, we're trying to make these changes across the lifespan and taking a micro, meso, and macro approach. This is showing our theory of change as we are serving families who have children ages 0 to 5 and addressing social determinants of health. Is a critical part of that as we are improving health outcomes and also preparing our earliest learners and making sure they're ready for kindergarten. And so here are some additional outcomes that we want to share with you. We have learned that we have also made reductions in preterm birth, and this has been tremendous. We have decreased that over the last year by 56%. We have also decreased low birth weight rates, and by 58%. We have increased our breastfeeding rates by 59%, an overall increase over the last 10 years by 63%, better than the city. And this has resulted in like 0 infant and fetal deaths as well. And so we celebrate this, but we know that there's a whole lot more work to do. We know that we must change the built and lived environments, and we must go upstream, which requires deepening our collaborative efforts across diverse sectors. This is one of my favorite slides. This gets into the work that we do in the community about promoting health literacy and literacy. And so we start early with this, with our baby basics books at pregnancy. These are the books that what to expect when you are pregnant, created for our moms when they're expecting, so they can learn at every step of their pregnancy, what it is that they may anticipate. And then we also distribute little free libraries throughout the community for everyone to access books for free. We ask that all of our participants have a library card during the 3rd trimester of their pregnancy. And once babies are born, we get them engaged in ENOP prac services, attending Mother Goose early on. And as Dr. Powell mentioned, our libraries have done a phenomenal job during the COVID-19 pandemic of making sure that they are addressing misinformation, making sure that they were providing services to decrease the digital divide, having computers available, distributing testing kits, and providing safe havens for youth after school. And so we greatly appreciate that. Overall, we have about 30 community-based partners who assist us in all of our work. And this is a picture of some of the work that we started during the pandemic to promote reading and advocacy. These are pictures of our quarterly article club. Parents are invited to attend. It's open to community members. We basically select a topic, and participants are allowed to read a quick article about something that is impacting their health, mental well-being, and they are able to share their perspectives and learn how others have also experienced that topic. And so we use this learning community to provide participants an opportunity to strengthen their voice, gain new insights, and become greater advocates as they are learning to make better informed decisions for their health and their community's health. And so over the years, we have partnered with the Health Science Library. Librarians have been critical. They have supported our community outreach efforts. They have met us at our pop-ups in the community where we educate folks. They have led health fairs in high schools, and they have informed us of grants that have supported our works. And so this is just some examples of ways that librarians can support future work, particularly as we are exploring opportunities for community members to become researchers. And so outsourced materials really matter. I want to stress that. The majority of our work involves engaging and educating community members and community partners, and it is helpful to be a part of the university community and gain access to peer-reviewed articles and newspapers. This helps us to see what other colleagues are doing in the field, and it would be helpful if when doing a search and reviewing peer-reviewed articles, if they linked to other sources such as The Atlantic and NPR, which interestingly cover similar health and mental health topics in their magazines. They cover stories of lives that have been impacted by health issues that our staff, our team, and community members find relatable and easier to read and understand. And so many universities can subsidize maybe access to the New York Times or the Washington Post, so that when we are sharing links for our article clubs, residents would not need to have subscriptions to read many of these articles, and that would be helpful. We also want to say that we would like a greater access to qualitative research. We listen to and collect the stories of women's birth experiences and birth journeys and their parenting memories monthly by story banking. And it is a way to collect this information as qualitative data for future articles, presentations, and funding. More importantly, the process of remembering and retelling and reclaiming individuals' stories is healing around addressing racial trauma and traumatic experiences. But it also provides ways for residents to see that they are not alone in these experiences. For example, like I think Vox article around Serena Williams' birth trauma really resonated with our participants. And so how can librarians raise qualitative research to support residents' lived experiences as they look to make changes in social conditions, built and lived environments and experiences within healthcare? That's another opportunity. And so then we also see opportunities for growth of residents and families as researchers, deepening relationship with public libraries and partnering with them. We've done a lot of that with Enoch Pratt. Enoch Pratt has done an excellent job, as I said, during the pandemic. And this really lends opportunities for residents to access the libraries in different ways. And so there are new opportunities that might emerge if we can reimagine how many of our libraries can continue to open themselves up to spark interest for future members, young members who may be interested in entering into medical and allied health profession. So what are new ways that librarians can engage and promote residents to research their own communities? And lastly, I want to offer this importance of bidirectional learning opportunities. I believe that in untapped, we have what untapped repositories of photos or documents exist in medical libraries of the lived experience of residents from surrounding cities and counties that might be of interest to residents. What pictures and documents might be of interest to medical librarians that families and community members may have? Many families keep journals and albums documenting their family histories and engage with librarians on their quest to better understand their family tree and genealogy. And what would it look like for residents to share some of this information about their family's lived experiences in the community and region? And how might this contribute to some of future research conducted by allied health professionals? Okay. And so here I want to leave you with examples of the community being abundant. We have found residents in our communities to be extremely resourceful, knowledgeable, giving, supportive of each other, and involved in supporting their communities. They are writers, artists, designers, entrepreneurs, and during the pandemic, they supported each other in phenomenal ways by providing food and providing masks throughout the community. Here are some pictures of our babies, and when we're out in the community doing work, they join us and support us in these efforts. This is our community advisory structure. We have our 8th group of peer leaders are joining us this week, former women who have been involved in our program, and they'll be joining us as 4 of them. And many of them in the past year, we were able to support them in becoming doulas and also lactation counselors. So we were excited about those opportunities. And these are examples of ways that we pivoted in the community. We had to respond and support mental health issues. And we offered meditation and mindfulness sessions. And we also provided food throughout the community, serving at least 200 people per month with healthy food to address food shortages and to support Black caterers in the community. This is an example of a journal that our moms created to encourage themselves as they were navigating and dealing with grief and loss and mental well-being. It was an I affirm you, we affirm each other journal. And then they created t-shirts to go with it, extremely creative. And so they walk out to the community and share the work and show how they have been involved and engaged in the work that we're doing. And finally, I just want to leave you with a quote that we received an email from one of our teen moms' parents expressing her gratitude to our program as we were working with her daughter during her pregnancy. The daughter had a baby and was able to remain in, the family was able to remain in their housing. And because of some funding that we provided for them so that they would be able to stay in their housing, she became a peer leader and a great support and promoter of the program within her own local high school. And she graduated from high school last year. Mom and baby are doing well. And so this was this mom's note to us, just thanking us for the services that we were able to provide. Here's our dynamic team that recently received this Jedi Award, and we are excited about this. And so I just want to thank the team for all the work that they have done. And we thank you for listening and considering opportunities and ways for you to deepen the work that you're doing in support of health and health outcomes of the communities in which you work in. Thank you.
Thank you, Stacy, for your presentation. I learned a lot more about the Be More for Healthy Babies program, so I was very happy to hear about that. We have time for, I think, one question for your presentation, Stacy, and I think it was also +1, so I'm going to read that one. It seems we cannot have conversations without calling out mothers-to-be for late or non-attendance at prenatal care services, and without citing statements about drug use in at-risk populations. How does the Baltimore Initiative account for these two mortality morbidity factors?
That's a great question. I think with all of our work, we really try that whole piece of building relationships with our families is critical and gaining trust. And so showing up, recognizing, just as we are looking at people dealing with hesitancy around vaccination, that is a part of folks accessing services, right? And it is incumbent upon us to really understand that that is a part of accessing services, that we're meeting people at their point of need and understanding what barriers may be in place for them that they are encountering in that built and lived condition. Is it that they are stressed? Is it because they have to work and they don't have childcare and they're not able to get into their prenatal visit? And so it is through relationships that we can learn this, that close proximity relationship, and deeply listening and understanding the obstacles. You know, transit equity and inequities are real. And so many of our families have challenges in making sure they're trying to make appointments and may have to go to use 2, 3, 4 buses in order to, get to the healthcare provider. And so we choose to look at those as contributing factors when we are interfacing and we are trying to explore ways to support. So I think that's really critical, that shift around not blaming individuals, but walking alongside individuals and understanding what has occurred for them historically and currently. Because what we do know is that I don't believe, and we hold this belief, that one, I think this is a mantra that all of us are using, that everyone is doing the absolute best that they can do in this time. And that we know that when a woman or a pregnant person finds out that they're pregnant, that they would like to make decisions around that pregnancy. We are giving them the space and autonomy to do so around that, and that they have the capability to do that, agency to do that. And so that's a little bit of a shift from the naming and the blaming. And I hope that answered the question.
Well, I hope so too. But thank you so much, both Stacy and Terri, for taking the time to present to everyone today. Also, thank you to all of our attendees for taking the time to attend our session. I apologize that we don't have time for more questions, but I will save the chat. So I know that there were a lot of articles that were shared and everything. I'd be happy to share that to both you, Terri and Stacy as well. And I want to let everyone know that starting at 3:45, we will have our final keynote presentation of the Research Symposium. Professor Jonathan Eldridge will present A Whole New World Relating to Research. At the end of the symposium, you'll see a new tab added to the conference platform labeled Evaluation. You may need to refresh your browser to see the new tab, but once you click on that link, it'll take you to a REDCap evaluation page. After you've completed the evaluation, you'll see the next steps you can take to earn 10 MLA CE credits. Thank you all, and we hope you've enjoyed the symposium so far, and we will see you at the final session. Again, thank you, Stacy and Terri. I really appreciate all of this, and I will be happy to forward everything that was shared in the chat box as soon as Margie ends the session, or Margie ends the session. I'm sorry, I mispronounced your last name, or first name, Margie.
Okay. All right.
All right.
Bye. Bye, everyone.
Thank you. Bye-bye, everyone.
Bye.